Vice Chair for Child and Adolescent Psychiatry, Psychology within the Department of Psychiatry, and I'm really pleased to introduce my colleague and the distinguished health economist, Richard Frank, for today's distinguished visiting lecture. Richard received his BA from Bard College in Econ, and then his doctorate from Boston U, also in Econ, before embarking on his career in health policy, particularly with regard to mental health and substance abuse, for which he's won major awards. He's not going to be talking today because we had a recent lecture on the opioid epidemic, although he's done some really important recent work in that. He's the Margaret T. Morris Professor of Health Economics in the Department of Healthcare Policy at Harvard Medical School. About a decade ago, he was the Deputy Assistant Secretary for Planning and Evaluation at Health and Human Service, directing the Office of Disability, Aging, and Long-Term Care Policy. Then, in 13 and 14, he was Special Advisor to the Office of the Secretary at DHHS. And then 14 to 16, he was Assistant Secretary for Planning and Evaluation in the Department of Health and Human Services. As you'll hear, his research is focused on the economics of mental health and substance abuse care, long-term care, financing policy, healthcare competition, health reform, and disability policy. He was elected to the National Academy of Medicine in 1997 and is co-author with our colleague Sherry Gleed of the book Better But Not Well, which is by Johns Hopkins University Press. I know Richard through our work with our collaborator at Berkeley, the health economist Richard Scheffler, and I admire both of their, particularly Richard, they're both named Richard, so I didn't advantage anyone, their blend of economics, basic science, policy, and mental health efforts, which are sorely needed more than ever today. He's made a big difference in the lives of many U.S. citizens and those around the world. So without further ado, please welcome Richard Frank.
Steve's very kind introduction, I think, was a way of saying that given how much time I spent in government, I'm kind of out of practice in doing said academics here. So I'm here in part to give you something I think really different. We're going to talk a little bit about economics. We're going to talk about robots, disability insurance, and so hopefully, if nothing else, it'll have entertainment value that way. So what I'm going to do is I'm going to start off just by giving you a little bit of context, and it will be a very brief, upbeat part of the story, which is that we've made some really important gains over the last few years. But then I'm going to sort of turn to what we know about mental illness and employment, and the role of employment, both in terms of its role in recovery, but also its role in integrating people socially. And then I'm going to take that and look at what the way that the evolving economy is going, what that means for employment and for people with mental illnesses. And then I'll sort of wind up by talking about some policy issues around some of the scary things that I raise. As Steve said, since about 2008, when the Mental Health Parity and Addiction and Equity Act passed, we've had a series of policies that have really dramatically improved what I'd call financial access to mental health care in the United States. And the Parity Act was followed by the Affordable Care Act, which then most recently was followed by the 21st Century Cures Act. And really, those three things put in an amount of money into mental health that we hadn't seen since the late 60s and early 70s. And so it really was a historical change. And then just last week, the president signed a bill that put $6 billion of new money into opioids alone. And so, again, I think that these issues are sort of front and center now. And the results are starting to show. And perhaps the best way to sort of summarize sort of some of the gains is just by looking at how many people's coverage for mental health care has changed over as a result of these policies. And so here's some estimates. Let me just draw your attention to the bottom line here. Anytime you do anything that makes things a little bit better even for 174 million people, you're doing what Vice President Biden said was a big deal. And he said that when the Affordable Care Act passed, and if any of you know how to lip read, he probably actually said things that were a little more colorful than that. Anyway, but if you recall, the Mental Health Parity Act, what that did is for larger employed populations, it required that mental health and substance use disorder treatment benefits be on par with those for medical surgical benefits, and that the care be managed in a comparable fashion. But it did not require coverage, and it only applied to those larger groups. The Affordable Care Act then extended those provisions to the small group and individual market and made mental health and addiction treatments part of the essential benefits, which essentially meant that all insurance policies in the United States needed to cover those. And so what you see below is that 30 million people had their coverage affected who were in small group markets. Now let me point out that within that 30 million, about a third of the people who had small group coverage did not have coverage for addiction or mental health treatment because they were underwritten out. So you could have insurance coverage for medical surgical conditions, but your policy wouldn't cover behavioral health. The individual health insurance market, which many of you know about because it's in the newspaper about 24 hours a day, that extended coverage to about 7 or 8 million people who hadn't been there before, and improved the coverage for the rest. So that was 18 million people. And then Medicaid expanded and then improved coverage also, which affected 23 million. So total, about 174 million people. And that has resulted in more care, more people getting treatment that's likely to get them better. And so in that sense, things have improved. Okay, so where am I going to take you? So while I think it's important to recognize and celebrate the gains that we've made in the last few years, I think we need to own up to the fact that we haven't done nearly as well integrating people, particularly with severe mental illnesses, into the American mainstream, into their communities, getting them jobs, getting them things that would allow them full participation in American society. And work is a central element of that. Work is important for community integration. It's important on its own, and it's also important as a piece of recovery, as a component of recovery. And so what I'm going to do is I'm going to share with you over the next little bit of time one of my major worries about mental health care and mental health policy for the coming decade or two. And I think what I'm going to do is I'm going to first sort of talk to you about what we know about that relationship between work and mental illness, but then talk about how the evolving economy is changing the nature of work in pretty fundamental ways, and how that is going to affect our ability to integrate people with mental illnesses, have successful programs that get them back to work, and again, make them part of mainstream America. Now, one of the ironies is if you think about how technology is changing the world, people with physical disabilities are seeing their opportunities open up dramatically. People who could not consider holding down jobs before now have incredible opportunities to be productive members of society. It cuts, I'm going to argue, almost exactly the opposite way for people with mental illnesses. And that, in fact, the technologies that are actually improving the prospects for people with physical disabilities are actually shrinking the opportunities for people with mental illnesses. So why do we work? Well, we work, first of all, for income and security, economic security. And just, looking around this room, I know a few of you, and many of you have your identities and your sense of self-worth tied up in your professional identities. And in fact, it is, work is gives us a purpose. It gives us a sense of belonging to institutions and to communities. And it also provides opportunities for exercising autonomy and independence. And there are other reasons. Now, these are true for kind of everybody in general, but they may be particularly important in the process of recovery and for people with mental disorders. So this table, I don't expect you to memorize it, but it is based on a review of the cognitive dysfunctions that are created by various types of mental illnesses. And red is implies kind of strong impacts on the skills, on the functional areas. And then green means not so much. And the sort of yellow boxes suggest that there is some impact, and it has some moderate impact on cognitive functioning. And so you see it's by disorder and by cognitive area. Let me make it easy for you and just sort of summarize it by pointing out that really there are the most prevalent disorders get in the way of some of the cognitive functions that are most important for being successful in the workplace. And those are concentration, problem solving, clear communication, memory and organization, adaptability, and collaboration. And what I'm going to argue is that, in fact, this set of skills is becoming more and more important, and many of the what I call old economy skills of physical capacity, ability to repeatedly do the same things fast, are sort of starting to trail away. So what are the consequences of having these kinds of work impairments or sort of cognitive dysfunctions? They fall into a number of categories. First of all, there's a general lower attachment to work among people with mental illnesses who have these kinds of dysfunctions. High rates of disability and therefore reliance on public disability programs for income support. High rates of poverty and social isolation. So I'm going to offer you up some data on most of these points. So on this table, let me draw your attention to the third row. which is the whether or not somebody has any employment or not. And this is the ratio. The numbers on this are the ratio for people with either severe or moderate mental level of impairment due to a mental illness compared to like people without those impairments, okay? And so if you look at that third row, you'll see that the ability to hold any kind of work is about 30% lower for people with a serious mental illness and about 17% lower for people with a moderate level of mental illness. Look at the line right above that, which is part-time, and what you see is that the likelihood of working part-time, if you do work, is much higher for people with a mental illness than those without, and that's because full-time employment is what most people do, and it's what people with mental illnesses do far less frequently. Okay? So basically, mental illnesses, particularly severe and moderate disorders, interfere with your ability to engage in the workplace, engage full-time, and when you do engage, you engage part-time. Now, if you take people with a mental illness and you compare them to people who are just like them except without, same education level, same age, same race and ethnicity, what you find is that they make about 70% as much money as do their colleagues without those types of illnesses. They're more likely to cluster in low-skill occupations. This is both in the U.S. and Europe. And the poverty rates for people with serious mental illnesses are 25 to 32%. Just to give you a basis of comparison, the overall U.S. Poverty rate is 13%. So we're talking somewhere between 2 and 3 times the level of poverty for this population as you see in the general U.S. population. Now, this is the trend in Social Security disability insurance enrollment due to a mental disorder. So what you see is about a little less than 2.5 million people are on Social Security disability insurance. And let me just remind you that in order to qualify for Social Security disability insurance, you have to have essentially worked for 10 years. And so you have to have an employment history. And so when you think about the onset of mental disorders, you have to have made it past roughly age 30 or 32 in order to qualify for Social Security disability insurance. And you can see that about a little over a quarter of the people on the program are on there because of a mental disorder. And I'm sweeping out people who have other forms of cognitive impairments. Now, supplemental security income, which is the other main income support program in Social Security, you see 42% of the people on the program today are on there because of a mental illness. Now, the reason that this number is so much larger is because you don't need to have that work history in order to qualify. And so because of the age onset of illnesses, particularly severe mental illnesses, you would expect more clustering in this program than in others. And again, you can see that there's been a pretty steady trend upward in the growth of this program. And while you can see there's a little bit of bumping around because of the nature of the economy, for the most part, for quite a while, it's been a fairly smooth upward trend. Okay, so that's what we know about the relationship in the kind of simplest sense between mental disorders and work. Let me now talk about where the economy has been and appears to be going, and what that means for these populations. So the first thing to do is to think about skill levels. And increasingly, the demands of the workforce for educational attainment in those sort of technical skills is growing. So if you look at the last 10 years, the job gains for people with post-secondary education have increased by about 5.3 million jobs, whereas occupations requiring a high school degree or less lost 1.3 million jobs over the last 10 years, okay? And for the most part, the last 10 years has been post-recession. And so you'd expect, if anything, these job numbers to be positively inflated. Now, what's important to recognize also is that roughly a quarter of people with serious mental illnesses have less than a high school education, compared to about 10%. So again, it's more than double what you see in the rest of the population, the sort of clustering at the low end of the skill distribution. Now, that's the recent history. Where this is going, the the Department of Labor projects that the job growth for people with like master's degrees and above is going to be about 16% over the next 10 years or so. For people with a college degree, it's going to be about 10%, and then it's going to be far less for people with just high school degrees, 5.2. So it's going to be somewhere between a third and a half the rate of growth in jobs at the lower end of the education and skill distribution. Okay, so Bureau of Labor Statistics, which is part of the Department of Labor. Okay. So this picture comes from the World Economic Forum. So if any of you ski, this is Davos. And what this is a review of what's been happening to the labor market's demand for skills over the last decade or so. And what you see is the growth has been in non-routine interpersonal and non-routine analytic skills, and there's been a fairly sharp decline in routine manual, routine cognitive, and non-routine manual. And so if you go back to what we were talking about in terms of the types of skills that mental illnesses interfere with, you see that that ability to be flexible, to communicate, to be adaptive, to be collaborative, to communicate clearly, those are all in the non-routine interpersonal and non-routine analytic. Being creative, being flexible, being quick on your feet in a sense, whereas the sort of more repetitive, routine types of operations, either manual or cognitive, are sort of falling by the wayside. And if you look at the World Economic Forum's projections on where we're going to need to be in terms of training people, again, what you see is in that middle segment of the picture down here, you see critical thinking and problem solving, creativity, communication, collaboration. Those are the skills that the economy is demanding going forward. And again, those are exactly the places where mental illnesses get most in the way. Before I show you the next slide, I just want to know, how many of you are scared of robots? Yeah, me too. I'm terrified. So this is what's happening with robots in this country. And what you see is over the last few years, 8 or 9 years, you see that robots and robotics have been growing at about 15% a year. And now they're projected over the next few years to grow at a higher rate than that, 17 to 20% a year. Okay? And so what you see is very much what people have been talking about in the popular press is increasingly certain kinds of jobs are being replaced by machines, and by machines that are much more sophisticated than the sort of Industrial Revolution types of machines. So here's where the machines are having their impacts. So we've divided the world into 3 chunks: people who make over $40 an hour, $20 to $40 an hour, and less than $20 an hour. And you can see that about 83% of the job replacements that are happening because of automation and robots are happening there at the bottom of the earnings distribution. Now, the bottom of the earnings distribution are those people with lower levels of education, lower levels of skills, and the ones where the jobs are the ones that are most consistent with being able to maintain people who have mental illnesses and the impairments that those carry. And so people with mental illnesses and who are in the labor market now are the ones whose jobs are most at risk. And the ones where we try to place people in recovery programs, those are the jobs that are disappearing. Now, there are some jobs, for example, some buildings and grounds work are not shrinking. They're growing. They're growing somewhat more slowly than other jobs, but they're growing. And those are consistent with the capabilities of lots of people with mental disorders, and in fact, people with mental illnesses tend to cluster in some of those jobs. Now, that is only partly good news, because in fact what's happening is those people who have low levels of education and low levels of skills who don't have mental illnesses are increasingly competing for those jobs. How many of you have read Hillbilly Elegy? Okay. Those people are the people who are increasingly competing for those jobs. And if you can imagine a competition between people who carry the burdens of mental illnesses and people who don't but have relatively low levels of educational attainment and skills, who do you think is going to win that competition? Okay? And sort of part of this is being driven by the automation and the computerization. So, pause for a second and say, it's clear that work is shifting, and it's shifting towards non-routine interpersonal skills, flexible skills, the ability to kind of problem solve and be creative. Mental disorders create impairments that interfere with the development of exactly those skills. And employment opportunities for people without those types of flexible cognitive and emotional skills are shrinking, and they're shrinking pretty fast. And again, to make matters worse, that last point is that competition for those jobs is increasing and increasing rapidly. So I think what this means is that the future prospects for employing people with mental illnesses, and particularly severe mental illnesses, is going to become increasingly challenging. Moreover, because so many of those jobs are going away, people who have currently been in the workplace, for example, with major depression and things, are going to see their opportunities shrink. And so people who previously were able to hold jobs, were able to sort of, in a sense, function in American society, are increasingly going to be marginalized. And it's going to be harder for them to hang on to those things because, in fact, their ability to hold substantial gainful activity is going to shrink.
Isn't this really a
The answer is yes, and you're about 5 slides ahead of me. but that's okay. I didn't have that proposal. That's an interesting one, but if you can hold on to that, I'll get there in fairly short order. Okay, so policy and pragmatic situations. It's nice to know that you were going with the flow here. Perhaps at the top of the list, when you start talking to people about this, and particularly clinical people, they will talk about sort of what we've been learning clinically about intervening early and perhaps being able to change the path of disability when mental illnesses come on. And so I'm going to talk a little bit about some of the interventions and some of the more recent therapeutic optimism that we have around first episode early intervention programs. Talk a little bit about disability incentives, and then look a little bit about what things we might do inside the workplace. And so, clinical, policy, programmatic, all of them are going to be important in solving this. So let me start by talking about early intervention. There's a lot of therapeutic optimism here. The NIMH's RAISE program has raised expectations because, in fact, they've seen some very nice results from it. The early intervention programs there show that early interventions, particularly those that make use of supported employment programs, result in greater work engagement than do people randomized to usual care, higher levels of social integration. However, so that's the good news. The not so good news is that it doesn't have any real effect on entry into disability programs, SSI and SSDI, and it's had no meaningful impact on earnings and income for these populations. So while it takes us one step in the right direction, social integration, greater work engagement, it doesn't do much to sort of really get at the sort of at least economic fundamentals. Now, one reason might be because RAISE was really a test about what do you do when you get somebody early in their course of illness. It doesn't tell us about, A, how you get people in, nor does it actually, for the most part, get people in that early. So the question is, do the RAISE results give us reason for real optimism? And I will argue a tentative yes. So the cost-effectiveness work that's come out of RAISE shows dramatic differences that occur when you get people early in their course of illness. So here we're measuring duration of untreated psychosis, DUP. And you can see that it costs about $1,000 for an improved quality adjusted life year when you get somebody within the first year and a half of their first episode, and it's 41 times that if you get somebody more than a year and a half out. Now, the important thing to remember is that the RAISE program, on average, brought people into the program 2.5 years into their psychoses. Okay? That is not, on average, what I'd call anything like early episode. It's clearly not a real first episode program, even though it was extraordinarily important in showing that what you do when you get somebody matters. So I think that that because on average the people that were studied here were actually fairly far into their careers psychosis, there is reason to believe that their results are a significant underestimate of the potential benefits if you were to get people really at the beginning of their episodes. And so there are other research going on that suggests other reasons for optimism. There are some programs that have added cognitive remediation as boosters above supported employment, for example, and have showed positive results. More importantly, there was a demonstration program put on by the government called the Demonstration to Maintain Independence in Employment, or DMIE. And what it showed is if you engage people while they were still at work, early in their course of illness, you actually had an effect on disability rates and you had an effect on earnings. But that meant getting people, engaging people while they were still at work and still sort of maintaining sort of those types of engagements. So I think we've now got a pretty good idea of what you do after people are engaged. We don't know very much about really how to engage people. But we have great opportunities to learn about that because over the next couple of years, we're going to learn what happened when the states had a set-aside in their block grants to put into place these early intervention programs. And we're seeing experimentation across the country in how you engage people. And so hopefully there'll be a tremendous amount of learning going on after that. I think the other challenge is going to be it raises a variety of really important ethical and programmatic issues about how do you engage people. If you are convinced that you need to engage people really early on, it means starting to kind of get involved in people's lives in a way that we don't typically do. And that means perhaps engaging people that don't want to be engaged, starting to treat people when you're not that sure, and so on. And I think there are a variety of ethical, legal, privacy issues that come up that we have to figure out in order to really design programs so that they're effective. But I think it is, the evidence points strongly to the need to really target short durations of untreated psychosis if you in fact want to really make a difference, because all the evidence that we have is pointing to the necessity of doing that and to engaging people before they sort of fall out of the ability to work and participate in programs. Okay, so let me now turn to a second type of policy issue, which is what do we do around disability programs? Now, we know a few things. Employers that carry private disability insurance make more investments in getting people to return to work, and the existence of our Social Security disability programs suggest that employers have an incentive not to worry about them, not to make those investments, because they can shift those costs onto the government. And the evidence suggests that return-to-work programs and disability management programs can be effective in returning people with mental disorders to work. So 2 proposals have been floated. One is to mandate private disability insurance, which would cause the employers to have skin in the game so that they made the investments in the programs that kept people at work. Okay? The Netherlands have had success with this. They've done very well on this, and it's been rigorously evaluated. The problem here is not a programmatic one, it's a political one, right? you've probably heard that we're not crazy about mandates in this country. And so the idea of sort of mandating employers is sort of a heavy political lift. A second approach is to do a version of what our colleague in the back there proposed earlier, which is essentially for employers that take on measures that reduce disability rates in their workers' population, make those investments, you give them a break on taxes for their Social Security disability insurance premium. And that then rewards them for doing the right thing in the workplace, tailors it to the particular workplace. The problem is it also creates an incentive to make sure that you don't hire people who are at risk of mental illness. And so you'd have to worry about that. Now, that's illegal, but it also means that you'd have to put an awful lot of faith into enforcement of the Americans with Disabilities Act. And that may or may not be a good bet. And then I think the other thing is to insist that health insurance programs that are employment-based use performance measures that reward folks that do good, that promote good mental health treatment in their insurance plans. And there's a lot of evidence showing that things like collaborative care programs in health insurance improve return to work and improve the ability to maintain people in the workplace. Last area I want to talk about is assistive technology. Now, there's been a tremendous amount of research on assistive technology related to cognitive impairment, but very little on mental illness per se. And it turns out that what has been done suggests that once people are stabilized, assistive technologies can be quite helpful. And it turns out that there's a platform here that at least I didn't know about till fairly recently, which is that people with mental illnesses, just like all other people, use technology a lot. 90% of people with mental disorders have one or more digital devices. People with mood disorders are more likely than people with schizophrenia, which is hardly surprising to have more devices. And 54% of people with mental illnesses have access to a smartphone. And that's just a little bit lower than the overall population. Now, the question is, how do they use them? Well, actually, people in fairly substantial numbers actually use the digital technologies to help manage their illnesses. 42% use it to manage symptoms. National Alliance for Mentally Ill did a survey a year before last. 37% use it to organize appointments and put in calendar reminders to take medications, go to appointments, etc. 28% of them use it for medication management and so on. And so there are opportunities here. There's a basis for creating assistive technologies. Now, what do we know about using assistive technologies to help support work? And it turns out there is some evidence showing that it can be done, but it requires a lot of ongoing training, and it has to be done in a way that personalizes things so it links to an individual's everyday tasks. And the primary ones are things like using this for reminders and task management, help for concentration through mindfulness and soothing, and then self-management through kind of monitoring risky behaviors, and also helping case managers and clinicians track patterns of behavior in their patients. So I think the evolution of the labor market is posing serious challenges to sort of where we thought we were going programmatically. Supported employment has been a big boon. There's been more effort made to sort of mainstream people with mental illnesses into sort of the workforce and the community. And I think that going back to the beginning, the very technologies that are helping people with physical disabilities are throwing up new challenges for people with mental illnesses. I think there is reason to be therapeutically optimistic about the ability to change the trajectory of disability if you do the right thing in engaging people early. I also think that aligning the incentives of employment of employers so that they actually take on some of the tasks of getting people supported and trained in the workforce can help. And I think technology has some potential to support work, but we need to do a whole lot more research and figuring out how to actually do it. And this is a dramatically under-researched area, and it seems to me this is a place where kind of clinical research, programmatic research, and policy research all come together to make a difference. So I'll stop there.
Questions, please. I'll start with one. Let me turn around so I'm not talking to the screen. I read a statistic a few years back that under ADA, under 10% of claims came from people with mental disorders, even though the accommodations are often flex time and they're very easy and cost-effective to manage as opposed to building a ramp or a wider bathroom, et cetera. Has that gone up in terms of, are you more optimistic that ADA can be enforced for people with mental disorders?
Well, two things. First, I actually, before I came out here, I went to the Department of Labor website to look at the complaints. And actually, the complaints for violation of the ADA due to mental illnesses has gone up. And so it's quite a bit higher than 10% now. I am not super optimistic about enforcement of ADA. And it's just because I think it's hard to make a clear determination of what the violation was, and it's hard to figure out exactly what the remedy is, just because I think the way the mental illnesses work, as you say, they're not like putting up a ramp. They could be accommodated, but they also require a lot more personalization, and it's harder.
To the extent that it's known, what kinds of jobs are good or tasks are good for people with mental illness? For example, let's say a young adult with schizophrenia.
Yeah, again, I think it's those tasks that are more what I'd call routine cognitive and routine physical. Things where there's either a repetitiveness or a kind of clear protocol in sort of what you do. And it's where there's sort of flexibility and needing to react and problem solve, particularly either on the interpersonal front or the analytic front, that becomes more challenging.
You commented on social isolation, and of course social isolation affects many of those with mental health concerns. So I found myself wondering, what about, and this may have already happened, what about peer-based mentorship programs where those individuals who have successfully confronted a mental health concern and obviously know a lot about how to manage their life
Yeah, no, I think that's a great observation, and it's actually one of the places. It's one of the things that's actually being done. The Medicaid program, in general, has opened the door to reimbursing peer supports, and not all states, but most states at this point are building peer programs and are building that into their state plans and are creating opportunities for reimbursement. And so I think that, and I think your observations are right. The experience so far has been kind of along the lines that you've said. Now, there's a couple of issues with that. One is even if it gets scaled up to a pretty large degree, it's only going to take care of a small portion of the population. Doesn't mean it shouldn't be done. We should do it because not only is it good for the people who are trained as peers, but it's really good for their peer colleagues, peer patients, if you will, who they work with. So I think there's lots of benefits to it. But in terms of trying to mainstream, deal with the social isolation, make it, we're not going to be able to put everybody on disability programs. And so we need to figure out how we get people reconnected or connected early and promote the skills that are going to be needed in the future for this population. And I think that's the big challenge, and that's what I worry about because I don't think we're paying enough attention to it.
So you talked about how kind of the jobs of the future, the jobs of today involve creativity, flexibility, and concepts. But there's also this growing area of kind of service industry and all sorts of jobs that involve never having to interview in person for a position at all. Things like Ubers or React, all these sorts of things. And so I'm just curious if you've seen any data as to where the segment of the population is falling into that job market, and whether there's more opportunity there, with the huge caveat that many of us have concerns about the fact that these are jobs that don't come with benefits, including health insurance, in a country that has made that connection between employment and health insurance.
Yeah, assuming that the Affordable Care Act continues to survive, the subsidies and things, I think there'll be opportunities to get health insurance. My name is Pollyanna, and I'm glad to be here. But so there is a bit of a debate going on, and it's not so much around things like Uber and stuff, but it's more around the sort of teleworking from home and things like that. And I think there is an argument saying, oh, those jobs look a little bit more routine. They're often sort of doing very routine sort of Q&A type things, and those are a possibility, and they allow people enough flexibility so they could accommodate illnesses. On the other hand, they are very isolating. They are not the kinds of jobs that at least employment programs usually think about in terms of promoting recovery. Is that? And so I think that's the tension there. And but I think it's a good question, and it's not a settled issue.
So what do you think that the mental health workforce needs to do to help meet these needs? Because we're talking about a lot of things that are not necessarily part of reimbursable routine mental health services. And then related, we see this big expansion of access to coverage, but not necessarily access to care. What do you think?
Yeah.
Basic things.
So I think the big trick is going to be around this early intervention stuff, right? Because it is asking the mental health system to really do business differently. One is you can't be passive and wait for people to come to you any longer. So we're going to have to figure out how to get a certain group of practitioners who really know how to go out into the community, engage them, and engage people in a way that's respectful of their privacy, of their autonomy, etc. And I don't know what that looks like yet, but I think that's going to be an important shift. I think that figuring out how to do supported employment on a skilled level with cognitive remediation, et cetera, which again has taken a back seat in terms of our clinical approaches to things. So again, I think that's another area where we're going to have to see business done differently. And then to layer on your last question is none of those things lend themselves to the way we typically run our insurance plans. And so I think we're going to have to come up with a different model, because you don't want to rely on Medicaid, because by the time people have gotten to Medicaid, it's often 2.5 years down the road, and we know from the data that's too late. And so we need to, we've spent the last 30 years hollowing out the public health financing system in this country. And I think, one thing that this is starting to challenge us to is we need a different financial model if we're going to sort of go heavily into these early intervention workplace type programs.
More and more of our clients are getting involved in the criminal justice system, and I'm curious if you know data that's taking that compounding variable into that.
Yeah, it is. And so this is, I've so far refrained from any obvious partisan comments, but here goes. Under previous administration, Eric Holder, who was the Attorney General, had this gigantic commitment that was administration-wide to reentry. And as part of that was really pushing state and local governments to change, and local employers to change their rules about employing people with criminal backgrounds. So, for example, in Baltimore, it turns out in Maryland you couldn't, there were all sorts of impediments to employing people who had criminal histories in the health sector. And in Baltimore, that's the biggest employer by far. San Francisco, probably not that different. And in fact, they ran a pilot program in Baltimore, and they found that with some solid training, people with criminal backgrounds actually were more stable and more likely to not be absent from work than the historical worker was at the Johns Hopkins health system. And so the administration was pushing those types of changes very, very hard. You've heard from our new Attorney General that they're doubling down on the punitive side, and so I'm concerned about that. That wasn't too bad, was it?
I had a question about supported employment. So I used to work at the Department of Veterans Affairs at the VA, where there was a lot of work that was done sort of coupling supportive employment with the clinical side. And I just had a question on, how, and that's just such a small population, how to really sort of think about incentivizing supportive employment for employers.
I think that was sort of what I was trying to get at a little bit by saying, if you either force them to have disability insurance or you give them a break on their disability insurance premiums if they make the right investments, then you sort of start to push employers into kind of thinking about what's effective. And at least my reading of the literature suggests that, at least for severe mental disorders, supported employment is about the best we've got right now, although I'm impressed with what I've been seeing in terms of layering cognitive remediation over that.
Yeah, so I'm heartened by the early intervention data,
think it does a pretty good job of getting people back into the workforce. But I have a concern about sort of, they're not long-term sustainable over decades. And I have a second concern, which is that when you talked about the cognitive skills that are important for the new economy, I was struck by the fact that I think actually our antipsychotic medications may actually impair those skills. And I'm wondering if there's, in any of the long-term cross-sectional data, do you see a treatment effect on any of these outcomes? For schizophrenia in particular, but SNI in general.
Yeah. I do think that, I think your observation is correct. I haven't seen great data that can isolate that, right? Because when there's employment studies, it's mixed up with a lot of other things, and so I think that's hard to sort out. But I agree with you, and I think that in the sense that cognitive remediation, some of these other points, the reason why they're important is because they sort of start to focus a little bit away from the treating of symptoms to the treating of functioning. And it seems to me that's a reorientation that's kind of worth it. You know, and what I think is interesting is that certainly some of the early intervention programs that I'm familiar with have been very judicious about dosing of the antipsychotics, I think in part for this reason. Well, actually, you already had, Chairman. Yeah. Yeah.
Thank you. You know, as an individual practitioner working with individuals, I've been really having a good time today listening to your wonderful talk and trying to translate point of intervention into sort of the kind of work that I do. It's been really interesting to hear policy-wide, worldwide in some cases, points of view about trends and populations and so forth. And what would you say to us as folks working with people who are somewhat demoralized by the current state of affairs? You mentioned optimism a few times as you went along, and I wonder what you would tell us, for us and for the folks we work with, about what might be getting better.
Well, I actually get this pretty often, and so let me just throw out a few kind of little factoids that might help you. You were born probably, I'm guessing, after 1975.
Well, thank you very much.
Right, okay. So then just before you were born, or just around the time you were born, there were still about 25,000 lobotomies being done in this country. We were still doing hydrotherapy on thousands of people. Okay, does everybody know what hydrotherapy is? They used to wrap people up in wet gauze, bring their body temperatures down really fast so it shocked them. And that was a way that was supposed to intervene with major depression, psychoses, whatever. We are getting more people stuff that's likely to get them better and not harm them today than ever in history. And it's very hard for somebody like you to see that, in part because you're helping to do that. And it's very hard to see it in that long term. And so I think that's one important thing. I think the other thing is that there are more people, if you look at the percentage of people with various illnesses, major depression, psychosis, etc., a higher percentage of them are getting treated today than ever in history. And they're getting treated with more humane, more effective treatments, even if the actual treatments themselves are not more efficacious, because in fact they're more tolerable and the professionals are more sophisticated who deliver them. And so what I would do is, because even though it's hard to see it day to day when people are looking at you in the face and dealing with the complexity of their problems, holding that in your mind, I think, should help a little bit.
So you're saying the medicine has gotten better and the politics have not?
So again, partisan Point two, I actually think that from between 2008 and 2017, things got a lot better for people with mental illnesses. So, for example, people who were coming out of jail in 2007 couldn't get Medicaid if they were in a halfway house with a mental illness or an addiction. Today, they can. We're bringing down the overdose rate among that population a little bit, even though the overdose rate is going up overall, because, in fact, we're able to link them to treatment, at least in the states that expanded Medicaid, which is 31. So I think the politics have gotten better. Also, you've never seen front page attention to addiction and mental illness like you have today. And people actually recognize, even in Western Kentucky, that this is something they need to do about, and maybe, in fact, medication-assisted treatment is just not replacing one addiction with another. And I think there is some improvement. Now, the downside of that is what it's often used for is it gives one group of people a lot of cover on the guns issue. And that's sort of a slightly depressing thing, but I won't go into that.
I'm wondering if you could talk about this sort of controversial idea that's coming up now under the current administration to institute waivers around Medicaid work requirements and sort of what your perspective is on such requirements and the role they may be playing in this issue.
I think they are really bad for people with mental and addictive disorders. Two things. I mean, for example, there's the actual conditions themselves, and then there's the sort of cart and horse problem. So let me start with the first. Hopefully what this whole blah, blah, blah about skills and stuff has shown is that when people with mental disorders have to kind of take sharp right turns and deal with a lot of bureaucracy and jump a lot of hoops, they don't do so well. And in fact, that's exactly what those work requirements do. You have to recertify every month. You have to fill out forms. You have to attest all kinds of stuff. And if nothing else, we know that will, from Social Security, something like 25% of people who might have been eligible, who were turned down the first time, never go back because the hassle's too much. And this is putting that on steroids, okay? So that's thing one. Thing two is, for example, in Kentucky, they have on the addiction side, you have to be in treatment 20 hours a week. What do you do 20 hours a week unless you're inpatient, right? I mean, what is that? And to me, what that is it's just setting the bar. And in fact, when you look at all the money they're saving, it's going to come on the backs of the most vulnerable people. And so, there probably is some way you could imagine putting together a work requirement that would be less harmful. But I don't believe that it's in the capabilities of most of our government programs to actually do it in a way that wouldn't massively hurt the most vulnerable people. But otherwise, I'm kind of iffy on the issue. I actually wrote an op-ed on this a couple of weeks ago. It was published in The Hill, which is sort of a Capitol Hill rag. Yeah.
I'm wondering, I don't think this has actually happened anywhere in the world, but there's increasing discussion in various economic and social forums for something, I forget, it goes by different names, but sort of a basic, not a wage, but a basic dollar amount of support.
Right.
What's the
Guaranteed income?
Guaranteed income, to provide basic food, clothing, and shelter. First of all, are there any areas where that has happened? To extrapolate, whether or not your thoughts of how that, if you incorporate, if in this country something like that ever happened, what are the intended and unintended consequences for our SMI?
Yeah. Well, a lot of Europe has it. They don't call it that, but they more or less have it. Anybody here remember Richard Nixon? He had a thing called the negative income tax. And there were experiments done around the country testing the negative income tax, which was essentially a guaranteed minimum income. And the experiments were reasonably successful, but the politics were not there. So, it is a, it was originally proposed by Milton Friedman, if you recall, hardly a paragon of the left. So, like most things, what used to be left is now right, and so on. And so it's, I think that you can design it so that you had ample work incentives, which was always the fear, is that it would create incentives not to work. But I think you can design it so that you have pretty strong work incentives. And I think that it would help with sort of some of the negative incentives in like the Social Security Disability Insurance Program, even though, what we know from supported employment experiments and things like that is that people with schizophrenia usually don't get anywhere near the thresholds that you would start losing benefits on anyway, but nevertheless, there are some that do. And I think that it would be doable, and it would create more flexibility than this, but it would be a major budget thing.
Sure. And in Europe, where this basically happens, what is the impact on this?
Well, the basic condition of people with, much of it's surprising. Many of the problems that we have with people with severe mental illness, they have the same thing in Europe. You probably saw I cited in a few places OECD data because, in fact, they worry about their disability programs. They worry about mainstream people. They worry about social isolation. They don't worry about homelessness in the same way. They don't worry about sort of the early mortality in quite the same way because, in fact, the social safety net is more robust.
That question, does that have anything to do with the amnios and thesis?
No, not really.
There's just worth adding that Stockton is doing, the city of Stockton is doing like an experiment right now in universal basic income, or they're calling it like a public dividend or something like that, $500 a month to some population.
Yeah, Alaska sort of did it with their oil money a while ago too. Yeah.
So I do recognize the numbers, 174 million people with access to coverage are impressive. And at the same time, of course, in no way implies that people have access to care. If you've ever tried to get an appointment with a child psychiatrist, there could be wait times up to a year. And of course, the leading cause of death is suicide. They all have coverage. So I think what you haven't specifically addressed is the system as it is has created enormously huge already, besides what they're planning next, administrative barriers for people to access care. I remember President Clinton a long time ago holding a card, it was supposed to be like universal access, you go anywhere, accepted by any willing provider. None of that is in place. So they're basically fiefdoms. Kaiser, Medi-Cal, they own patients. They cost a lot more than I would cost. And people cannot take the benefits and go to a willing provider. They can't.
So we should never ever have this argument using child psychiatry as an example, because that's a cherry-picked statistic. Right, exactly. I understand, and I feel I feel your wealth, and I think that I think for the most part, it's absolutely right that we have a huge access problem for child psychiatry everywhere in this country, and it applies, and it applies to rich people and poor people alike. So let's set that aside. If you look at the data, actually, if you look at data in terms of people with depression, schizophrenia getting care that looks evidence-based, getting young adults getting inpatient treatment, getting addiction treatment, people with an opioid problem getting medication-assisted treatment. All of that has increased dramatically over the last 10 years. I mean, dramatically. More importantly, if you look at the number of people with serious emotional, I forgot what the term is, but it's that K6 index, serious emotional problem, disturbance, thank you. The rates in places that expanded Medicaid have dropped dramatically compared to states that didn't expand Medicaid. And there are two reasons for that. One is that they're getting treatment, but that's only about half of it. Half of it is because people feel more secure. And so together, I think it suggests that we've made improvements. Do we have a long way do we have a ways to go? Absolutely. Do we have pockets that are unconscionably bad? Child psychiatry being one of them. Treatment for sort of more routine, like major depression that's not psychotic depression in Texas. Big problem. If you're poor and you have major depression, you're really out of luck in Texas. So I think that there's certainly lots of things to be upset about, but there's also, I think, lots of things to celebrate on that score. But I'm still worried about this other stuff. Okay, good.